Okay, so we are gonna be talking about heart failure and dysrhythmia. Another name for dysrhythmia is arrhythmias and common sequels of cardiac disease. Okay, heart failure. What is heart failure? Heart failure is the heart doesn't have the ability to pump enough blood to cover the metabolic demand of our body. Okay, that's basically the general concept of heart failure. Uh, Result in congestion of blood flow. We are going to see this later. Increased incidence, most common reason for hospitalization in those over 65 years old. Okay, then we are going to be uh, pathogenesis of heart failure is the potential consequence of most cardiac disorder. For example, hypertension, myocardial infarction, cardiomyopathy. All those cardiac conditions can lead to heart failure. Okay, and common manifestation, those are signs and symptoms. We have dyspnea, especially on exertion, that means during exercise, pulmonary rales, cardiomegaly, pulmonary edema, S3, also S4, tachycardia, and also we have paroxysmal nocturnal dyspnea, that's a dyspnea at night, and one of the most important sign and symptom of heart failure is autotonia. Autotonia is that the patient can be laid down. So that's why when you are in the hospital that you have a patient and you're suspecting that the patient have heart failure, one of the first question is, do you use pillows at night to sleep? That's a classic question, okay? The patient is gonna say, of course, doctor, I have to use like 3, 4, 5, I don't know. I have to sleep basically in a sitting position, okay? Because when they get laid down, have shortness of breath. Okay, heart failure is divided in, these are one of the divisions, systolic dysfunction and diastolic dysfunction, okay? Systolic dysfunction, one of the most common etiologies is MI, myocardial infarction. So in this, when you have reduced contractility and the ejection fraction, that's special for systolic dysfunction. Decreased ejection fraction, okay? That's how you distinguish systolic from diastolic, okay? In systolic, you have decreased ejection fraction. In diastolic, ejection fraction most of the time is preserved, okay? Impaired contractility involves loss of cardiac muscle, and those are some receptors that we have in cardiac muscle. Diastolic dysfunction is coronary artery disease and hypertension are the two main causes, more likely to develop in elderly. Disorder of myocardial relaxation, remember that this is during diastole, and the ejection fraction is normal. You can see right here, normal ejection fraction, okay? The patient low cardiac output, congestion, edema. And we have question number 1. A nurse read in the chart that the patient have an ejection fraction of 15. This is consistent with a diagnosis of, then you have to know if you have systolic or diastolic heart failure. But first, you have to know what is the normal ejection fraction. Nobody know what is the normal ejection fraction? No? Okay, normal ejection fraction is more than 55. Sorry. 55, okay? That's the normal ejection fraction. So the answer right here is B. B, remember. Systolic, decrease ejection fraction. Diastole, I mean B. Okay, perfect. That's that. You got the concept. Okay. So systolic, that's dysfunction, decrease ejection fraction. Diastole, normal, preserve ejection fraction. Okay. Ectopia and vasovagal, that's another history. Heart failure, compensatory mechanisms mechanism and remodeling. Okay, help in restoring cardiac output toward the normal over the long term are detrimental to the heart. Current management of heart failure direct toward reducing the harmful consequence of those compensatory mechanisms. Okay, and the compensatory is central nervous system activation, increased preload, and myocardial hypertrophy. And here we have the sympathetic nervous system activation, primarily as a result of baroreceptor reflex. Okay, systemic nervous system increase activity in the sympathetic nervous to the heart, resulting in venous contraction. Justoglomerular cell release renin. Okay, listen, heart failure. The main thing that you have to know about heart failure is this. Okay? That's basically heart failure. Heart failure is RAS, RAS, RAS. Okay, I'm gonna explain this. Let me see what is the next slide. Increase preload, myocardial hypertrophy and remodeling. Okay, let's go back. Okay, listen. Okay, what happened with heart failure? Remember, heart failure is that the heart doesn't have the ability to pump enough blood to the metabolic demand of the body. Okay, so if you don't pump enough blood to the body, 25% of the cardiac go to the kidney. So the kidney have this, the juxtaglomerular cell, and the juxtaglomerular cells have the macula densa. Right there, you have cells that sense for perfusion, that is volume, and sodium. Okay, those are the two things that they are sensing. So if you don't have enough perfusion, that means that the heart is not pumping enough blood, the perfusion to the kidney decrease, volume to the kidney decrease, so blood flow to the kidney decrease. All that perfusion, volume, blood flow is basically the same. Everything decrease to the kidney. What happened? The kidney release this renin. Then renin activate angiotensin. Angiotensin activate angiotensin converting enzyme. Angiotensin converting enzyme combine angiotensin 1 to angiotensin 2 in the lungs. Angiotensin 2 go to the suprarenal glands, and the suprarenal gland release aldosterone. Aldosterone go to the kidney in the convoluted tubules, and in the convoluted tubules they reabsorb sodium. Remember, if you reabsorb sodium, water follows sodium. That means you retain fluid. If you retain fluid, you increase volume in the body. Okay? And that's the main mechanism of heart failure. When you increase that volume, that means all those excessive fluid is gonna go to the third compartment space in our body. What are the main third compartment space in our body? The lungs, the belly, and the extremity. That's why people with heart failure have pulmonary edema, that is pulmonary congestion, because fluid stay in the lungs. They have, sometimes they develop ascites, even ascites more common in heart failure, but they could develop ascites, but especially they develop peripheral edema, okay, retention of fluid in the whole body. So right there you have all the mechanisms of heart failure. Okay, you have right here increased preload. What is preload? The amount of blood that is reaching to the heart. You increase preload. Why? Because you activate RAS. There is more fluid in the body. Okay, the problem is that all that fluid, the heart doesn't have the ability to pump that fluid. Okay, myocardial hypertrophy. Of course, you have myocardial hypertrophy. Remember that if you are increasing the preload, then that means that the heart has to work more, and then that produces hypertrophy. Clinical manifestation: left ventricular failure most common, often lead to right ventricular failure, forward failure, insufficiency cardiac pumping manifest by poor cardiac output. Well, the main thing that we measure in heart failure is ejection fraction, okay? Left side heart failure. Okay, remember that heart failure we already covered is divided in systolic and diastolic dysfunction, okay? So in systolic dysfunction, the ejection fraction is decreased. In diastolic dysfunction, ejection fraction is preserved, okay? Now we have left side heart failure and right side heart failure, okay? Now, remember, left side of the heart get the blood from the lungs, and all that blood that comes, all that fluid, all that volume that comes from the lungs is pumped forward to the whole body. So if the heart lost the ability to pump that fluid, the fluid is back up to the lungs. So those patients is going to develop pulmonary congestion, edema, fluid in the lungs, and they develop these crackles, okay? Bells, wake crackles, okay? Those are extra sounds in the lung, okay? Of course, everybody with heart failure have dyspnea, dyspnea exertion, attonia, paroxysmal nocturnal dyspnea, all those, but these pulmonary edema, pulmonary congestion, and crackles in the lungs are especially for left side heart failure. Now we have question number 2. Which of the following is the finding unique to left side heart failure? Who knows the answer? Okay, the answer in this question is also this question is not really good. It's churners of bread. So if they instead of right here churners of bread, they put pulmonary edema is a better question, okay? Because pulmonary edema is for left side heart failure. Peripheral edema is for right. Okay? This is right side. Okay. Churners of bread is basically for both. Okay. So this question, the answer is D. Right side heart failure we have right here. Again, remember that we have the right side of the heart receive the blood from the whole body, collect all the blood from the whole body, and pump that blood to the lungs to get the oxygen. So if the heart lost the ability to pump that blood, again the blood, the fluid, the volume back up to the whole body. That's why you have peripheral edema. You have edema in the whole body. Okay. The lung differentiate. Okay. Normally, people in real life, the presentation of people with heart failure, they have all the symptoms. Okay, because they have the pump, both right and left are not working properly. But to differentiate one to another, in right side, peripheral edema, left side, pulmonary edema. Okay. Biventricular heart failure is when both the left side and the right side fail, and the patient have reduced cardiac output and have a symptom from both deficiency. Okay. Last on the stage of heart failure, phases: fatigue, activity limitation, congestion, edema, shortness of breath. Diagnosis essentially include X-ray, and basically this is the main diagnostic tech. Okay, brain natriuretic peptide. Okay, it's a peptide produced by the brain due to the heart failure. Okay, you measure that, and I think you're over 500. Gone diagnostic. And right here we have the severity and symptoms is identified in 4 classes. Okay, we have 4 classes. That is for the New York Heart Association, and class 1, 2, and 4, and it's according to the severity and symptoms. So if the patient have uh, decreased ejection fraction with no symptom, class 1. If you have symptom with your daily living, class 2. If you have symptom, sorry, the other way around. If you have symptom during exercise, that's class 1. So the only time that you develop the symptoms during exercise. Class 2 is when you have symptom which, when some activity like walking, like going up the stair. Class 3 is when you have symptoms with your daily living, like just moving around the house. And class 4 is when you have symptom at rest. Now right here, the treatment of the heart failure is always target the RAS. Okay, so you have to target the RAS. So that's the main treatment for heart failure. You have to target the RAS. Unless you have a heart failure exacerbation due to a complication like MI or something else, then you have to treat the condition that is producing the exacerbation. Then you, when the patient is stable, you go back to the normal treatment. Okay, but always you have to target the RAS. Okay, that's the main treatment. That's why we use furosemide, that is a diuretic. Also, we use ACE inhibitor, ARS, beta blocker. Also, we use spironolactone. Improve cardiac digitalis. Sometimes we use digitalis, especially when the patient is in exacerbation. But normally, digitalis nowadays is basically not in use anymore. Okay, it's not widely used. Inhibit the CNS effect. Beta blocker, more than CNS effect, beta blocker also work in the RAS, because the juxtaglomerular cell macula densa, they have beta receptor, and then that's why we use beta blocker. Also, we have ACE, ARS, and pacemaker. You have a condition that need a pacemaker, you put the pacemaker in the patient. Now we have cardiac dysrhythmia. Another name is arrhythmia. Normally, when you go to the hospital, you always hear about arrhythmia. Okay, that's abnormality of the cardiac rhythms. We have 3 major types. We have a normal rate of sinus rhythm. Sinus rhythm is the normal rhythm of the heart. A normal side, that is a topic of impulse initiation and disturbance in conduction pathway. The arrhythmia is significant for 2 reasons: for indicating an underlying pathophysiology disorder, or for impairing normal cardiac output. The arrhythmia mechanism: impulse generated, abnormality in rate of impulse generated from the normal pacemaker. The normal pacemaker, we have the SA node and the AV node. SA node is the pacemaker, the main pacemaker. Arrhythmia initiated by 3 types of depolarization mechanisms. A normal automaticity. Automaticity is the normal rate control of the heart. Okay, that every beat of the heart start in the SA node, then go to the AV node, then from the AV node go to the bundles of His, and then Purkinje fibers. Okay, and then you complete the whole depolarization of the heart. Trigger activity from depolarization and reentrant circuits. Automaticity, spontaneous regeneration of action potential. I already explained. SA node, AV node, bundle of His and Purkinje fibers. Okay? Trigger activity of cardiac arrhythmia occur when an impulse is generated during or just after repolarization. Okay? Result from repolarizing oscillation of the membrane potential, early occurring in phase 3. Remember that the heart cycle has like 4 phase 0, 1, 2, 3, and 4. Okay, and delay occur in phase 4. Okay, is related. Phase 3 is related to calcium voltage, and phase 4 is the calcium ions spontaneously released. Okay. Now we have the re-entry. That's another mechanism that produces also arrhythmias. Okay, associated with most arrhythmias, cardiac impulse continue to depolarize in part of the heart after the main impulse has finished its path and the majority of the fibers are repolarized. Myocardial ischemia and electrolyte abnormality predispose to re-entry depolarization. Can have wavelet or shades tail. The arrhythmia analysis, how do you know that the patient have arrhythmia? EKG. Okay, always you have to do EKG. Normal sinus rhythms. Right here you have the normal sinus rhythms. That means that the rhythms is regular. It's like tup, 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 tup. That's a normal rhythms. It's between 60 to 100. That's for adult person. Okay, in newborn babies in childhood, that rhythm, that's another history. Okay, that's for adult person. Regular rhythm, starting the SA node. Okay, that's the main pacemaker. Always starting the SA node. Then go to the AV node. Then go to the bundle of His and Purkinje fiber. Okay, P waves precede every QRX. That's extremely important because if you don't have P wave, most of the time you have atrial fibrillation. Okay, that's one of the main characteristics of the atrial fibrillation. Then we have PR, QRS, QT interval. Remember the EKG is P wave, QRX complex, and P wave. Okay. Sinus tachycardia is a normal fast heart rate or of greater than 100, often a compensatory response to increased demand for cardiac. For example, you are doing exercise, and that's completely physiologic. Sinus bradycardia is when the rhythm is under 60. Okay, may be normal and physiological trained individuals, people that do a lot of exercise, normally they have bradycardia at rest. That's completely normal. Okay, usually from parasympathetic activation is a slow heart rate, possibly low cardiac output may include sympathomimetic or parasympathologic drugs. Okay. Now we have sinus arrhythmia associated with fluctuation in autonomic influence or and respiratory dynamic. May be particularly pronounced in children, may be differentiated from sick sinus syndrome, may need a pacemaker. Sinus arrhythmia is a normal and need not treatment. Okay? Sinus arrest, that's another history. Accent of impulse initiation in the heart result in electrical asystole. Electrical asystole means that there is no pulse. Okay? It's when you see the flat line in the EKG, that is asystole. Okay? Escape rhythm and a slower pacemaker will generally begin to fire after several seconds of sinus arrest. Pacemaker may be required. A normal site of impulse initiation of cardiac impulse at the site other than the SA node. Sometimes initiate in the AV node. That's why is the normal site initiate the rhythm is in the SA node. Escape rhythms is originated in the AV node. Remember that we have SA node, then AV node. If you initiate in the AV node, that means that you escape the SA node. Okay? Ventricular Purkinje fiber, so from AV node all the way down. Okay. Junctional escape rhythm originate in the AV node, rate of 40 to 60 is normal QRX. Ventricular escape rhythm originate in the Purkinje fiber is even lower, and P wave abnormal or accent. Atrial dysrhythmia, premature atrial complex originate in the atrium but not the SA node. Remember that the SA node is in the right atrium. Okay. PACs occur earlier than normal, preceded by a P wave, and have a normal QRS complex configuration. Frequent PSA may indicate underlying pathophysiology process and be precursors to more serious dysrhythmia. Paroxysmal focal atrial tachycardia, bursts of atrial complex resembling several PSAs in a row. Okay, now we have atrial flutter and atrial fibrillation. Okay, listen, I'm gonna explain this. You have a better idea. Okay. Cardiac arrhythmias are divided in two main groups. Okay, are divided if the heart is really fast or if the heart is slow. Okay, if the heart is really fast, then we have tachycardias like ventricular tachycardia. We have atrial flutter, atrial fibrillation, ventricular fibrillation, okay, sinus tachycardia. Those are fast. Also, we have the Wolff-Parkinson-White. That's another ventricular supraventricular tachycardia. Those are arrhythmias that are fast. Then we have arrhythmias that are slow. In the arrhythmias that are slow is the block, okay? All the block, all the AV block. In the AV blocks, we have AV block 1, AV block 2, that is divided in two. We have the Morbix 1, Morbix 2, and AV block 3, okay? Okay. Junctional dysrhythmia may be initiated by two junctional zones, areas just proximal to the AV node, or areas just distal to the AV node. Junctional tachycardia is a rapid junctional discharge from 70 to 100, resembles a series of junctional premature beats with P wave preceding, following a barrier in the QRX complex. That means that is inside in the QRX. Okay. Supraventricular tachycardia may refer to junctional or atrial tachycardia. Ventricular dysrhythmia, we have a premature ventricular complex arrive from the ventricular myocardium, do not activate the atrium or depolarize the sinus node. It's a bizarre QRX. Compensatory pulse is common. Is Vicky Mines, even other every other beat, or 3G Mine every third beat. With high frequency, cardiac output may be compromised. Ventricular tachycardia is 3 or more consecutive ventricular complex at a greater rate than 100 beats per minute. Remember, this is a fast tachycardia, okay? Remember, tachycardias, arrhythmia are divided in fast and slow. This is one of the fast, okay? P wave are not associated with the QRA, but you have P wave. Okay, always you have to find the P wave, because if you don't have P wave, it's atrial fibrillation. Okay, may be fatal if not rapidly managed. Antiarrhythmic drug, CPR, and electrical cardioversion. Okay, again, treatment for those arrhythmia are divided in the two main group. Okay, if you have a fast tachycardia, that means that you have arrhythmia that is fast, that is more than 100 beats per minute, then the treatment is always medication or this cardioversion, synchronized cardioversion. Okay, if you have arrhythmia that are slow, then the treatment is medication. Always first is medication, and then if the patient is unstable, the other treatment is pacemaker. Ventricular fibrillation, this is a special, it's a rapid uncoordinated cardiac rhythms. You're gonna see the EKGs like that. Okay, and you see that is basically ventricular fibrillations. EKG is rapid and erratic, and this is extremely important. Why? Because you have to defibrillate the patient. If you don't put the patient in the defibrillator, you could give CPR the whole day. The patient is not gonna overcome the ventricular fibrillation. The patient is going to die. Okay. And we have question number 3. Which patient should the nurse assist first? A patient with exactly ventricular fibrillation. An ejection fraction of 75, that's sometimes compensation because that ejection fraction is really high. First degree AV block, that condition most of the time is completely asymptomatic and doesn't have any treatment. Okay, sinus arrhythmia sometimes is a physiological response, or is completely benign. You don't have to treat the patient. The only one that you have to treat right away is ventricular fibrillation. Okay. Okay, also remember that we have right here CPR. You have to be very careful with CPR, okay? In order to give CPR to the patient has to be no pulse, okay? When you touch, there is no pulse, you start CPR, okay? If you feel the pulse, doesn't matter if the patient is in any type of arrhythmia, you don't give CPR, okay? Be careful, even because sometimes the people confuse that the patient is, syncope episode, then you have to, is unconscious on the floor, you have to do CPR right away. No. The first thing that you have to do, there is pulse, no CPR. There is pulse, yes, no CPR. Okay. Conduction pathway disturbance include delay, block, or abnormal pathway. Conduction block and delay associated with cardiac ischemia and infarction. Abnormal pathway, usually congenital. We have atrioventricular conductions, atrioventricular block. Remember atrioventricular block, we have first degree block, second degree is divided in type 1 and type 2 is Morbix 1 and Morbix 2, and third degree is a complete block. Those patients have to go straight to pacemaker. Let me see. Remember, type 1 most of the time is completely asymptomatic. You don't have to do any treatment. In type 2 is the Morbix 2, okay? Or Weckenbach, okay? That's another name. How do you know this? Is by the EKG, okay? You have to know the EKG. I'm gonna explain really fast because you don't have to know that. It's not for this level. But for example, in order to know that the patient is in a block, you have to know the PR interval, okay? So in first block, there is prolonged PR interval, okay? That first degree block, prolonged PR interval, and the patient is in bradycardia, okay? Most of the time less than 60. In type 2, the patient have prolonging, so the PR is gonna be elongating, and then you are gonna have a P wave and no QRX. So you drop the QRS, and then you have P wave again, QRX, and then you have to measure the PR interval. This is the PR interval right here. So in type 1, you have prolonging, then type 2, you have prolonged, okay? The PR is prolonged, okay? And then you have prolonged PR until QRX is dropped again. That's type 2, okay? And type 3, there is no association between the P wave and the QRX, okay? So the heart is beating by itself, the ventricle is beating by itself, and the atrium is beating by itself, okay? Abnormal conduction pathway, accessory pathway, congenital anomaly of the cardiac conduction system. Okay, one of the main is this Wolff-Parkinson-White. Wolff-Parkinson-White is special because they have a delta wave, okay? You have a P, and then in the QRX, you have something like this. That's the delta wave right there. Sorry. I don't know what happened right here. Wait. So I was explaining that this is the delta waves. It's classic in those patients. Most of the time, this condition is congenital, and you don't know. That's why nowadays there is a recommendation if you have a child that is practicing a sport, before they start practicing a sport, you do an EKG in childhood. Basically, it's for teenagers. Okay. Now we have interventricular conduction defect, bonded branch block, a normal conduction of impulse through the interventricular bonded branch. Okay, bonded branch, we have right bonded branch block and we have left bonded branch block. Okay, also both you're gonna see in the EKG, and you could Google it and put EKG with bony ears. That's because that's the description. Okay, you are gonna see like bony ears in the EKG, and that's the bonded branch. According to the lip that have the bony ears, is either right or left. The treatment indicate when arrhythmia produce significant symptoms. Most of the time you give a drug, okay? And it's according to the type of arrhythmia. Any question from here? Okay, if you don't have any question, let's go to the next chapter. We have chapter 20. Now we're gonna be talking about shock, okay? Give me 1 second, okay? So in shock, we are gonna see that imbalance between oxygen supply and oxygen required at the cellular level. Okay, shock represents a diverse group of life-threatening conditions. Shock is always a life-threatening condition. Common factor among all type of shock is hypoperfusion. Hypoperfusion, why? Because the patient develop hypotensis. The patient is hypotensive. That's the main characteristic of shock. The patient is going to be hypotensive. What means hypotension? That means systole less than 90 and diastole less than 60. Okay, that's hypotension. For an adult person, okay, childhood is another history. Here we are talking about internal medicine for adult people, okay? Cause, we have cardiogenic, obstructive, hypovolemic, and distributed, okay? This is extremely important. Obstructive, you have to know the different type, okay? We have pulmonary embolus, cardiac tamponade, okay? Impaired tissue oxygenation, impaired oxygen utilization by cell, disrupt function, and if ongoing or severe, may lead to cell death, organ dysfunction, and stimulation of inflammatory reaction. Lack of oxygen causes several outcomes. Production of lactate, and lactate produce lactic acid, and that produce most of the time pain. Impaired tissue oxygens result in cellular hypoxia, which cause anaerobic metabolism, free radical production, and macrophages induction. Reperfusion injury is one of the complications that can produce oxygen-free radicals, okay, because the oxygen produce free radical, and that can produce some complication in the patient, okay? Impaired tissue oxygenation, tumor necrosis factor alpha, and interleukin-1 cytokines increase in septic shock and are thought to be important mediator of vascular failure and progressive organ damage, okay? Increased activity of inducible nitric oxide as a special for septic shock, okay, septic shock, because nitric oxide produce vasodilation, and when you produce vasodilation, you make venous pooling. Venous pooling means that the blood stay in the veins, and then that produce hypotension, okay. Compensatory mechanism, stage of shock, 3 clinical stage: compensated shock, progressive shock, and refractory shock. Compensatory stage homeostatic mechanisms are sufficient to maintain adequate tissue perfusion despite a reduce in cardiac output. Sympathetic nervous system activation attempts to maintain blood pressure, of course. You try to make vasoconstrictions to increase the blood pressure. We keep going with compensatory mechanisms. Progressive stage of shock is marked by hypotension and marked tissue hypoxia. Lactate production increase with anaerobic metabolism. Lack of ATP leads to cellular swelling, dysfunction, and death. Cellular and organ dysfunction result from oxygen-free radical, release of inflammatory cytokines, and activation of the clotting cascade. Now we have the cardiogenic shock. What happens in cardiogenic shock? Most of the time is associated with MI and complication of MI, okay? Diagnostic feature: decreased cardiac output, elevated left ventricular end diastolic pressure, that is the preload, you increase the preload, S3, and pulmonary edema. Cardiogenic shock, we have low CO. Basically, in all the shock, the cardiac output is always low, okay? There is only one shock that the cardiac output is high, and it's in septic shock. It's the only one. Okay, to tissue, we have therapy aimed to improve CO and myocardial oxygen. Okay, in cardiogenic shock, one of the main medication is called pressors. Okay, you could Google it, pressors, and the pressors, the function of the pressor are those inotropic, preload reducing, and afterload reducing aging. Okay, intra-aortic ballooning counter pulsation, ventricular assist device, heart transplantation. Now we have the obstructive shock. Obstructive shock results from mechanical obstructions that prevent effective cardiac filling and stroke volume. Common causes include pulmonary embolism, okay, cardiac tamponade, tension pneumothorax. Tension pneumothorax is accumulation of air in the lungs, not in the lungs, in the pleura right there, the pleura space, and that push the lung. And when you push the lungs, basically you deviate everything and you make obstructions in the inferior and superior vena cava, and there is no return of blood to the heart. That's why you produce the hypotension and decreased cardiac output. Manifests as a right side heart failure. Rapid management of underlying obstruction is required to prevent cardiovascular collapse. Hypovolemic shock. Hypovolemic shock is, the name said, what happens is the volume is low. It's due to leakage in your body, okay? Most of the time is hemorrhage. When you have hemorrhage, you could develop hypovolemic shock, okay? Again, the CO, the cardiac output is gonna be low always. Okay, right here, that's compensatory mechanism. If you have cardiac output low, you are going to elevate the heart rate, vasoconstriction, and increase contractility in order to maintain the blood pressure. Hypovolemic shock, we have severity, we have 4 classes, you don't have to know this part. And therapy is aimed at fluid replacement. In those patients, you have to give plenty of fluid, okay? Crystalloid, okay? Crystalloid. Forget about colloid, okay? Colloid is just that type of fluid is used, for example, in people that need protein because colloid contain protein, okay? The most commonly fluid used in hospital is this one, crystalloid, okay? Right there in crystalloid, you have the normal saline, half saline, 3%, 5%, all the type of D5W, all the bringing lactate, those are colloid. Now we have distributed shock. Distributed shock, we have different types. That is anaphylactic shock, neurogenic shock, and septic shock. Okay. Anaphylactic shock is due to an allergic reaction. Okay, it's a massive allergic reactions. Okay, that is mediated by immunoglobulin E. Okay, most of the time the people that at one point they develop anaphylactic reaction, they always carry with an EpiPen because that's the medication epinephrine. Okay, you see mast cell release vasodilator, you have a massive dilation in your body, and remember, you make massive vasodilations, you increase the size of the veins and the artery, and all the blood is retained in the veins. There is no return to the heart, decreased cardiac output, and as a consequence, blood pressure go down, okay, hypotension. Anaphylactic shock, clinical symptom, urticaria, bronchoconstriction, stridor, angioedema, wheezing, itching, okay. Treatment include manifestation of airway pattern. Most of the time, the first thing that you do in those patients is epinephrine. If the patient don't react to the epinephrine, epinephrine again. If the patient don't react to the epinephrine, you intubate the patient because you have to save the airways, okay? Neurogenic shock is a result from loss of sympathetic activity of arterial smooth muscle. You see, again, if you lose the sympathetic activity, that means there is going to be vasodilation. Okay, that's why in every type of shock you have hypotension. Okay. Causes include medullary depression, brain injury, drug overdose, or lesion of the sympathetic nervous system in the spinal cord. Treatment include vasopressor. Vasopressor is the common medication for any type of shock. Okay. Septic shock result from severe sepsis. Okay, especially gram-negative bacteria. Okay, right here, common gram-negative bacteria, and also gram-positive bacteria. Okay. Gram-negative shock endotoxin in bacteria cell wall stimulate massive immune system activation. Okay, characterized by release immunomediator resulting in widespread inflammation. Also, you could activate the chlorine cascade and produce uh, uh, pulmonary embolism. Okay. Uh, Widespread inflammations lead to profound peripheral vasodilation with hypotension, maldistribution of blood flow with cellular hypoxia, and increased capillary permeability. That this permeability lead to edema. Septic shock, initially characterized by high cardiac output, is the only one shock that the cardiac output is increased. Okay. Let me see, let's keep going. That's the most important part right here, okay? Therapy aims and improve the distribution of blood flow, the management effective with antibiotic. You have to give antibiotic most of the time, extremely potent antibiotic, okay? And we have question number 1. Which of the following type of shock is septic shock, okay? Remember that you have to know the different type of shock, okay? And the answer right here is this distributed shock, okay? Remember, obstructive shock, right there you have pulmonary embolism, you have this one, tension pneumothorax, also you have cardiac tamponade. Assessment and hemodynamic monitoring, helpful for assess cardiac output, volume status, and oxygen delivery and consumption. Right atrial pressure, pulmonary arterial pressure, and left atrial pressure monitor. You have to monitor all these because in order to know all these values give you the type of shock, okay? You always have to know the cardiac output, the right atrial pressure, okay? And sometimes they refer to preload, afterload, okay? Now we have cardiac output. Cardiac output, we have the preload is the amount of blood in the ventricle at the end of diastole. That means all the blood that is inside the heart, okay? And afterload is the aortic impedance that the left ventricle must overcome to eject blood during systole. In another word, afterload is the pressure that is after the aortic valve, okay? And contractility is the ability of the heart to make contractions. Arterial oxygen content, oxygen delivery, oxygen consumption. Right there you have how we describe medicine. Normally 25% of oxygen in arterial blood is extracted from tissue, so mixed venous oxygen saturation is 75. Low C cardiac output result in greater oxygen extractions. Maldistribution of flow result in less oxygen extraction and higher SpO2. Okay. Hemodynamic monitoring, pulmonary arterial catheter insert via jugular and subclavian vein. That is when the patient most of the time is in ICU. Okay. Right atrial pressure, that is the right preload. Left atrial pressure, that is the ventricular preload. Hemodynamic monitoring, also we have pulmonary pressure is used to detect pulmonary complication, pulmonary arterial Diastolic pressure reflect left preload. Pulmonary capillary occlusion pressure is a direct measurement of the left atrial pressure. With all those measurements, you know what is the type of shock, okay? Because there are some table. You don't have to know that, but there are some table. And with all those measurements, you know if the shock is cardiogenic, safety, okay? Now we have question number 2. A nurse is monitoring pulmonary capillary occlusion pressure. What does this measure? Exactly, that's the left atrial pressure. Perfect. Okay. Remember the capillary arteries end in the left atrium. Okay. Shock state result in reduced or inadequate cellular oxygen consumptions and may affect all organ and system of the body. Complications are inflammatory in nature. Inflammatory cytokines mediate organ damage. Remember interleukin-1, tumor necrosis factor alpha, okay? Damage and altering metabolism, recruiting neutrophil, initiating of coagulation cascade, and altering capillary permeability. ARDS is a complication of patients that are already in the hospital, okay? That's how you know that the patient have ARDS, okay? It's a patient that is in ICU and develop respiratory problem, ARDS, okay? Like now you can see ARDS, for example, in people with COVID. Most commonly associated with septic shock, development of refractory hypoxia, decreased pulmonary compliance, and radiographic evidence of pulmonary edema. Okay, that's one of the main characteristics of ARDS, pulmonary edema. Okay, you have pulmonary edema, and then the pulmonary edema means that this is the blood vessels. Okay, this is the alveolar sac right here. If you have edema, this part right here, okay, so this part right here, do you get septic shock and then develop this? Yes, exactly. Let me see, somebody, do you get septic shock and then develop this, or get ARDS first and then, no, you develop septic shock and then ARDS. Yeah, ARDS, listen, ARDS is a extremely complicated pathology, okay? How you memorize ARDS? Patient that is already in ICU, extremely complicated, and develop respiratory failure, okay? That's ARDS. But the pathophysiology of ARDS is this. This side right here facilitate the diffusion of oxygen, okay? Oxygen go right here, okay? Go from the alveolar to the blood vessel. If you increase this gap that we have right here, then you decrease the diffusion capacity of the oxygen. Then there is no oxygenation. That's why you develop hypoxemia and the ARDS. And it's mediated by the inflammatory mediator, okay? Neutrophil release proteolytic enzyme, those are inflammatory mediator, and those are the ones that produce the edema and decrease the oxygen diffusion capacity, okay? And then you produce the respiratory failure. Disseminated intravascular coagulation also is another complication, sometimes of septic shock, okay? Remember, in septic shock, you have infection with bacteria, especially gram-negative. Those produce toxins, and those toxins can activate the coagulation. If you activate the coagulation, you have consumption of the platelet and the coagulating factor, and then the patient is at risk for bleeding. Do most people die of septic shock, or do antibiotics usually work? Okay, I can answer that question. Okay, that has to be a person hospital. But septic shock is an extremely heart condition. It's really hard to treat those patients because the infection is completely disseminated in the whole body. But we have a lot of antibiotic, really potent antibiotic. Also, we do the antibiotic susceptibility test. You get the fluid of the patient, you culture those fluid, and then you know the bacteria that is in that patient, uh, to what antibiotic is susceptible. Susceptible means that that antibiotic is gonna kill that bacteria. Okay, but always you have to start with empiric treatment. Empiric treatment is based on the most common pathogen. Okay, so you start in empiric treatment, and 3 days later, when you get the susceptibility test, you maybe stay with the same antibiotic or change to the best antibiotic. But the outcome, I really don't, I can't give you that answer because I don't know. Acute renal failure is another complication of those patients that have a lot of problem going on in the body, and the most common one is this acute tubular necrosis. Okay, because acute tubular necrosis is an intrinsic uh, acute renal failure, and most of the time it's due to the hypoperfusion. Right here, you have hypoperfusions, then you develop acute tubular necrosis. You see that when you have a patient that is in shock, they have multi-system failure. So if you get to this point that the patient develop ARDS, acute tubular necrosis, then at this point the outcome of that patient is gonna be really really bad because the patient have a lot of complication. Okay, you see, maybe you have to dialyze the patient, put the patient in dialysis to clean the kidney. Also, we have multi-organ dysfunction syndromes when 2 or more systems are affected. Most common cause secondary uh, mods is sepsis and septic shock. Okay, the difference between sepsis and septic shock is the hypotension. Okay, in sepsis, you have disseminated infection in your body, but the patient is normotensive. In septic shock, you have disseminated infection of the patient, and the patient is hypotensive, initiated by immune mechanisms that are overactive and destructive. Cytokines affect endothelium, recruit neutrophils, and activate inflammatory in vascular beds, leading to tissue destruction and organ dysfunction. We have question number 3. If a nurse observes this sign and symptom in a patient, which complication of shock is the patient experiencing? Decreased platelet, decreased fibrinogen, elevated D-dimer. What's the answer? C. Exactly, it's a DIC, disseminated intravascular coagulation or coagulopathy. And right here you have a clinical case that is for you to study. You don't have to do any report. It's just for you to study. All the answer is in the original PowerPoint. Any question? Hello, hello. Any questions?